I welcome her once again to this Mera India lecture series. Professor Mitali Chatterjee is a professor and head of the pharmacology department at Institute of Postgraduate Medical Education and Research, Kolkata. After completing her MBBS from Medical College, Kolkata, she obtained MSc from Cancer Research Unit, University of Newcastle from Tyne, UK. She subsequently completed her MD Pharmacology from University College of Medicine, University of Calcutta, followed by PhD from Indian Institute of Chemical Biology, Kolkata. During her academics, she bagged various prestigious fellowships like J.C. Bose, Fellow of TWAS, the World Academy of Sciences, FRCP, Fellow of Royal College of Physicians, London. She has been honored with eminent awards like Janki Ammal, Senior Category, Women Bioscientist Award by DBT, Dr. P.N. Chhuttani Oration by NAMS, Kshanika Oration by ICMR, and many more. Her initial scientific career was focused on visceral leishmaniasis. She has established a Leishmania parasite repository and also found various contributory factors of antimonial resistance in clinical isolates. Currently, her research work is focused on understanding the immunopathology of post-kala-azar dermal leishmaniasis, PKDL. Her group is also involved in active surveillance for PKDL and helping in quantifying the neglected burden of macular PKDL cases. Besides this formal introduction, I'm working with ma'am from past, around 10 years now, and I have not seen enthusiasm of that level in any person I have met. I remember it was at the initial days, COVID had not disrupted lives, and we were into developing a proposal of standardized PCR protocols, and she was taking the lead for all the other institutes. And that was such a wonderful opportunity to meet as a funding body to the agencies which are receiving funds at such a close quarters. And it's such a pleasure to work with you, ma'am, officially as well, and to have you here. Over to you, ma'am. Thank you.
Okay. So thank you very much, Dr. Manju, for the wonderful introduction. And really, I am extremely honored to be able to give this lecture, to reach out to a wider audience, and also, speak a little bit about not just our work, but also what I want to highlight is the fact that most of the work which I will be presenting is work which is relevant to our country, and most importantly has been done, established, and improvised and fine-tuned by researchers from India itself. So a disease of our country which has been handled by medical scientists and others, also researchers. So I will move into my talk, and let me just share my presentation. Am I there?
Yeah, ma'am, we can see the screen.
Okay. So good morning to all of you in different parts of India and perhaps in other areas too. It's really a pleasure to talk to you about a disease that I have really been very passionate about, and researchers all over who also work on leishmaniasis. We call ourselves leishmaniacs. So leishmaniasis is an ancient disease. It has been with us because in the 1st century AD, there has been pottery which has been identified in Peru and Ecuador, where there are features of cutaneous leishmaniasis. This disfigurement that you can see of the nose and the face is because the individual was perhaps infected by the Leishmania parasite. For us in India, the importance began in the 20th century when William Leishman and Charles Donovan identified the mastigotes within the splenic aspirate of an individual, and slowly we learned more and more about the disease. So why is it important to us, and what is leishmaniasis about? I'll just do a little bit of a brief overview about this digenetic parasite. It is a very interesting parasite in that it has two forms. One is the promastigote form that is within the sandfly vector, and the other form is within mammalian hosts. The host may be dog in some parts of the world, but in our part of the world, it is the human which is the host. They finally multiply within the spleen and the macrophage, within the splenic and the hepatic macrophages, and they manifest in the form of visceral leishmaniasis, or kala-azar as it is known. Kala-azar is perhaps the only disease which is in a medical textbook which is derived from an Indian word. So kala-azar, as the name suggests, kala of course is black, and azar in Bengali means fever. So it was hyperpigmentation which occurred and fever which occurred. Now what was interesting also is that this kala-azar was followed by dermal manifestations in some patients of kala-azar, and it acquired the name post-kala-azar dermal leishmaniasis, where patients present with papules, with macules, or just overall hypopigmentation. So why is visceral leishmaniasis or kala-azar important for us? Globally in the world, it is considered as one of the world's neglected tropical diseases. Neglected tropical diseases, as the name suggests, is essentially those diseases which occur in tropical countries but unfortunately remains neglected. It remains below the radar of global health funding agencies. It kind of is lower in priority as far as global health diseases is concerned, and unfortunately occurs usually in the most impoverished, the poorest of poor communities. So it is our responsibility to address this disease and find out ways by which we can make the ongoing elimination program into a reality. So the new cases that we have in 2021, as reported by WHO, is only 11,743, which makes it an achievable, the elimination an achievable target. And what is really important is if we see the proportion of distribution of kala-azar cases, Southeast Asia, which originally contributed almost 60 to 70% of cases, we now contribute only 13% of cases. So truly we can make kala-azar elimination a reality, and that is where PKDL also needs to be addressed to truly make it a success story. So this kala-azar elimination program that we have had in Southeast Asia in particular, the success was because there was liposomal amphotericin B, which was made available. A single infusion of lamb liposomal amphotericin B effectively eliminated the Leishmania donovani parasite, and the availability of a serological test, the RK39 strip test. These two, made India and Nepal and Bangladesh come together. In 2005, we came together and signed an agreement was signed that we would aim to achieve, set a target for ourselves. We have unfortunately had a series of missed targets due to various reasons. I wouldn't go into it, but there was resistance to antimony being one of them. But by 2015, it was realized that unless we address post-kala-azar dermal leishmaniasis, we will keep, having to push the target further and further. So two things were done in 2015 is that active surveillance for cases of PKDL was strongly recommended, and we now stand at 2023. And if you see the remarkable success that we have had, at 2007 we had 44 cases, but now in 2022, as on November 2022, we are down to 834 cases. So there is much to feel proud about. And why was this achievable? It was achievable in the Indian subcontinent because man is the only host, sandfly is the only vector. We have an excellent diagnostic test available. We have very good effective drugs in the form of liposomal amphotericin B, and the geographical spread is limited to 4 states, which is Bihar, West Bengal, Jharkhand, and Uttar Pradesh. So that makes 54 districts. And as we are today, it is only present in 1 district. So we have almost 99.8% success, which has been reported. And that is also because a strong political commitment also contributed towards this elimination. Now, still, where are the targets that we are missing? We still have a few last mile challenges. And one of the last mile challenges that we need to address is the fact that it has been observed that when kala-azar occurs, there is an epidemic of kala-azar which occurs in that there is a resurgence, in that there is an upsurge in the number of cases. So if you look back in 1934, there were far more cases which occurred. But every 15 years or so, between 15 to 20 years, there has been a resurgence which has been occurring. One was in the mid 1970s. There was another one which was in the mid 1990s. Another one which occurred in 2004. So this was interesting in that we have these epidemics. They occur in waves. There is a decrease in the numbers which was attributed possibly to DDT spraying, which was actively done. But again, it reappeared. So was it just drug resistance? The DDT didn't work, or were there other factors also which played a role? So the question which arose in many people's minds, people who work in kala-azar, is there a disease reservoir which is present? And this disease reservoir helps in this resurgence which occurs in 15 years, every 15 to 20 years. So for this, I need to take you back 100 years. 100 years ago, in 1922, at the Asiatic Society in Kolkata, Sir Upendranath Brahmachari proposed and showed actually cases. He said that he observed that a number of cases of kala-azar, individuals who had kala-azar, appeared with skin lesions. He obviously did not know what these skin lesions were, and it's very interesting, so I cite this. So he says he proposed to call this form of cutaneous leishmaniasis. He called it a dermal leishmanoid, and he made an analogy with that of smallpox, and he said that he called it a varioloid. But remember, this was 100 years ago, but at least he made this observation, and this observation was so pertinent. It was extremely pertinent to know that cases of post-kala-azar dermal leishmaniasis followed from kala-azar. So unfortunately, this disease, PKDL as we know it, is also a neglected tropical disease. It falls within the category of leishmaniasis, but we believe that it should not remain neglected. So what are the efforts that have been made and what can be made to make not only kala-azar eliminated but also eliminate cases of PKDL? So why is PKDL so challenging? PKDL is challenging because even though visceral leishmaniasis occurs in many parts of the world, often kala-azar occurs, cases of VL occurs as a part of HIV co-infection, but the PKDL follows in only 2 pockets in the world. This is really very fascinating in a way. There are only 2 pockets in the world where kala-azar is followed by the dermal features of PKDL. And one of them is the Indian subcontinent. And by that, it includes mainly India, Bangladesh, and Nepal. And the other is in East Africa and namely includes Sudan. So there are only 2 pockets in the world, and this is probably what adds to the challenge. And what is even more challenging is if you think the parasite is the same. It is the Leishmania donovani parasite, which is the causative organism. But if you look at the features of the disease, it is really quite fascinating to see that the same parasite, the same Leishmania donovani parasite, has such interesting differences. So what are the differences that we have between the PKDL that we see in East Africa and the version that we have in the Indian subcontinent? The first difference that is there is that in East Africa or in Sudan primarily, it occurs along with kala-azar. It occurs concomitantly with that. Within about 6 months or so, features of PKDL appear. So I wouldn't call it post-kala-azar, and it's actually called para-kala-azar dermal leishmaniasis. Whereas in India, it is much more challenging because it can occur at any time point. The interval can be anything between 1 to 10 years, and so we refer to it as post-kala-azar dermal leishmaniasis. In East Africa, almost every alternate case, 55 to 60% of VL cases, will present with kala-azar dermal leishmaniasis. They would usually be papular nodular lesions, but they also have hypopigmentation. And what's very, very important is majority of them actually heal spontaneously. So it's not a disease that one would really worry about in East Africa, but in India, it is unfortunately not the same. It occurs only in 10 to 20% of cases. So it would be really nice if we had a biomarker which would tell us which VL cases would transition into PKDL. Is there a genetic basis for why a kala-azar case moves towards PKDL? These are some of the questions which arise in our mind, and they are being worked upon. What would the individual present with? The individual would present with a combination of macules, papules, or nodules, and does not undergo spontaneous cure. It requires treatment, and the treatment is very prolonged. It needs almost 12 weeks of miltefosine. So that's what really makes it challenging. It is a rare disease, a rare component of a neglected tropical disease, and yet unless we identify it, we will never be able to make this elimination a reality. So we need to address the problems. And why are these considered as the reservoir? They're considered as the reservoir because if you look at the dermal lesions that you have are usually, not always, in sun-exposed areas. So in sun-exposed areas, if you see on the nose, on the face, often on the back also, they are present over here. Here is at the neck. On the tongue also you may have features. So the sandfly has easy access. All the sandfly needs to do, if you look at this lesion over here, all the sandfly needs to do is just sit on one of these lesions and they get a nice juicy blood meal which is full, teeming absolutely with Leishmania parasites, mainly the amastigote form. So now the sandfly takes a blood meal from this individual and then can infect many other members in the community. So this neglected reservoir needs to be addressed. But what are the challenges that we have? The challenges which are there is that they only come with skin manifestations. And these skin manifestations for these individuals, they are usually the poorest of the poor in the community. These skin manifestations have very low priority as far as their daily lives are concerned. So they would not actually go to a doctor. Their treatment seeking behavior, their health seeking behavior is very, very poor because it is only an aesthetic issue. It is not life threatening. It does not cause any problems in their daily lives, and therefore they won't even seek treatment. So the other problem that is there is a fair degree of social exclusion. There is a degree of stigma which is associated because there is hypopigmentation. So people confuse it with leprosy, people confuse it with vitiligo, and so these individuals who are already marginalized would be marginalized even within their society. So the tendency to seek treatment is very, very limited. The other problem that we have is that these individuals often present with hypopigmentation. So if you see these cases that you have, all they have is hypopigmentation. This can easily be covered if they wear a full sleeve shirt or the woman covers herself with a sari. So these cases of macular PKDL are actually a mobile interepidemic reservoir. They are in the community. The sandfly has access to these lesions. The LD bodies, the other challenge is the LD body is not identified in a number of cases, but parasite DNA has been identified. So how does one confirm that PKDL is truly the disease reservoir? So for that, you can actually do it in two ways. One, what you can do is take an aspirate from here, push it into some medium. And when you push it into the medium, from this particular individual, we took some aspirate from his lesions, we placed it into a tissue culture medium, and the next day itself, the amastigotes had converted, and we could see these clumps of promastigotes. The other way to do it, and the way that it has been confirmed, is that PKDL is definitely a strong contender to be the disease reservoir for kala-azar is by xenodiagnosis. And xenodiagnosis essentially is when you would take an uninfected vector, you take uninfected sandflies, place them on top of a skin lesion or place them on top of a skin lesion, a PKDL lesion. They will take a blood meal from there, and then these sandflies are examined for the presence of parasite DNA. And this study was done and it was confirmed that the parasite load from 3 patients they found ranged from 1,000 to almost 63,000 parasites were present per microgram of genomic DNA. So yes, these are individuals who can keep carrying the disease. They are the mobile disease reservoir, and therefore we need to actively find them. So since kala-azar became a notifiable disease in 2015, there has been a very active program for identifying these cases. So since December 2014, active case detection became, this was actively promoted, and it is now a part of the disease elimination program. So here what we did was, and what others also did was, instead of the patient coming to us, instead of the patient coming to the outpatient department, the doctor went to their homes. So usually these would be homes where there were cases who had a history of kala-azar. They were examined by the kala-azar treatment supervisors, the technical supervisors, the KTS workers, who identified suspected cases of PKDL. So if they came with any skin lesions, they were then brought to a medical camp. When they came to a medical camp, they were examined by dermatologists and by physicians. If they had a strong suspicion, then a skin biopsy was collected. If there were cases of kala-azar, of course, peripheral blood and an RK39 strip test was done. And for cases of PKDL, a dermal biopsy was sent. Our institute became the nodal center for these cases of PKDL. We developed a PCR and subsequently also a quantitative PCR. If there were cases, we informed them, and they were given 12 weeks of miltefosine was given to them. So this program that we had of active case detection, what did it translate into? How did it help in the, did it really translate into better care? It did indeed. Active surveillance was a real game changer, because if you focus on 2014 and you look at the change that is there, the red line that we have are the cases of PKDL that we have. I'm only limited here till 2016 because what I wanted to highlight was how the cases with active case detection being enforced, the number of cases of PKDL increased dramatically. And this increase that took place was not because there was some sort of a resurgence or an upsurge of PKDL. These were just cases that were being detected. So we had anything between 500 cases of PKDL. In Jharkhand, it was 900. In West Bengal, it was in the range of 200 to 250. But what the message was that we needed to go to the patient, we needed to identify these cases, bring them into the treatment fold, and once they will be brought into the treatment fold, we hope that that cycle, that those waves and troughs that we were having, those cycles of epidemics of kala-azar will not occur. So what did we learn from this active surveillance program? There were several changes that we realized. If we look at the textbook knowledge that we have, was that kala-azar and PKDL there is male predominance. It is a male dominated disease because this was the era of passive surveillance where the number of cases were in the range of 1:3 cases. But when we went through to them and we did when we did active surveillance, it showed that there is no gender bias. Males and females are equally affected. Another important thing which we identified was that the textbook knowledge that we had was that 90% of cases have a combination of nodules, papules, and macules because they possibly are aesthetically damaging and so they seek treatment. So there was a threefold higher proportion of polymorphic cases in the passive surveillance. But when we went to the field, it showed that actually the ratio of macular is to polymorphic is almost equal. It's almost 1:1. So these were the two important changes, and it was important for scientists and physicians to learn that macular and polymorphic are present in equal amounts. Maculars usually have less amounts of parasite, but their power of transmission is as good as that of polymorphics. Males and females should both be brought into the treatment fold. Unfortunately for us, the laboratory diagnosis of PKDL still remains empirical. The diagnosis still remains empirical. We do not have a defined way because the gold standard still is identification of the LD bodies. But if we look at the number of macular cases, which are almost 50%, they will not have actually the LD bodies which are present. You can do the strip test, the RK39 strip test can be done, but that can also be positive because the individual would have a past history of kala-azar, and so there may be just skin lesions due to pityriasis, there could be skin lesions due to vitiligo or leprosy, and yet they would be positive for by RK39 strip test. So there is a need for better tools and people are working on it. I think what was important was that development of molecular diagnostics probably will help. So in that regard, molecular diagnostics have come into the mainstream. A qualitative ITS1 PCR is available, but still it is in a research mode. But what is important also is that a real-time PCR has also been developed. What information did the quantitative real-time PCR give us? It gave us important information that the parasite burden in macular and polymorphic PKDL is in the range of, the maculars were in the range of about 3,000 parasites, whereas the polymorphics had a much higher proportion, is almost 5 to 6 times higher cases. So this would be a case of macular PKDL where there is a very widespread hypopigmentation, and this would be a case of polymorphic where he had number of papules and nodules, and he also had on his hand, he had a number of lesions. So this is the scenario at disease presentation. What is the treatment that we have for these individuals? The treatment of PKDL, unfortunately, still remains, has not been clearly defined. It still remains a category C in that it is not yet clearly defined. There is no formal clinical trial which has taken place, simply because it was not because there is no effort which has been taken, but more because during passive surveillance, very few cases of PKDL would come to the OPD. But now that we have active case detection, I think we are in a strong position, and I am aware that PKDL clinical trials have been taken up, and I hope that it will reach the point of publication very soon. So far, what is the treatment choice that we have? The drug of choice that we have is oral miltefosine. Oral miltefosine can be given depending on the body weight. Is if it is more than 25, 50 milligrams morning, evening, 100 milligrams daily after meals for 12 weeks. That's a long time to give. But it has been seen that less than that, there was persistence of parasites which was taking place. In children, it can be given at 2.5 milligram per kg once daily. The second drug of choice, if the individual cannot tolerate miltefosine or does not respond to miltefosine, then the second drug of choice is conventional amphotericin B, which is given as an IV infusion. What are the limitations that we have with regard to long-term miltefosine? It has been seen that there are a number of gastrointestinal symptoms which have been reported. In about 30 to 40%, they report severe vomiting and diarrhea. And this is a real problem because they simply just don't take their medicine. So that is why there is poor adherence which occurs, and this would increase the chances of drug resistance to occur. Another problem is because miltefosine began life as an anti-cancer drug, it has the risk of teratogenicity. So it must be avoided in individuals, in women of childbearing age, or they should be on some form of contraception. So pregnancy must be avoided during treatment, and even in the following 2 months after completion of treatment. Is directly observed therapy an option? This is something we need to consider because the poor adherence can lead to drug resistance. We have a very limited armamentarium. We just have miltefosine and amphotericin B in our bag. So we need to be careful that drug resistance does not occur. Another problem which has occurred very recently with miltefosine is ocular disorders have been seen. What are the ocular disorders that have been reported? There have been cases of unilateral and bilateral blindness. Fortunately, it is reversible in most individuals. There is resolve with discontinuation of treatment. Ulcerative keratitis, blurring of vision can occur. Patients have complained of photophobia. So the WHO has issued a warning that individuals must be informed about this possible risk of ocular disorders occurring. An ocular examination must be done prior to treatment. Treatment may be stopped if ocular disorders appear, and what is important is ocular adverse events must be reported to the National Pharmacovigilance Center. So this is very important because we must not lose this drug. Miltefosine is an invaluable drug for the treatment of miltefosine, and we should be aware of these possible ocular disorders, and we should, if there is an individual who comes with ocular problems, treatment should be immediately stopped and alternative treatment offered. So now the next thing is, how do we monitor these cases? How are we sure that the individual has been successfully treated? So for that, molecular tools are necessary. Molecular tools would help to quantify the number of parasites. For that, it was important that tests be developed and molecular diagnostics are available. We have the quantitative real-time PCR, which can tell you that what was the disease load at presentation and over a period of time, is it decreasing or not. We also have the loop-mediated isothermal amplification assay, which has been developed by the group at the National Institute of Pathology in Delhi, led by Dr. Ruchi Singh. They have a kDNA-based LAMP assay, which is field applicable. You can clearly see that this is a negative case and this is a positive case, and this can be taken to the field. So it is very important that we test this and hopefully it will see the light of day. We also have a recombinase polymerase amplification assay, or the RPA assay, which is also field applicable. So the need of the hour is that we have a test of cure tool available which has good sensitivity and good specificity. Now for this to be able to enforce this assay, we would need to collect biopsies at intervals. So for that, we need to keep that in mind. That to have the patient's cooperation, we need to have minimally invasive approaches. And for that, there is a microbiopsy tool which is available, which is being tested, and hopefully it will be available and we can actually use this for monitoring treatment. Treatment has been monitored by the quantitative PCR approach. The quantitative PCR approach was used for quantification of parasite load at disease presentation and also at the end of treatment. And if you see this horizontal line, this is the cutoff line. Below this is negative, above this is positive. So at disease presentation, all these patients of PKDL were positive. And with treatment, with the 12 weeks of treatment with miltefosine, there was clear-cut reduction. As far as clinical features are concerned, if an individual has hypopigmentation, it is actually difficult to monitor because the hypopigmentation, the repigmentation for melanin to reappear often occurs well after the parasites have disappeared. So this is a challenge that we have. So treatment completion, we need a tool. We need a tool which will tell us whether there is parasite or the parasite DNA has been completely cleared. So these are tools that we need to think about. There is also the availability of a suitcase-based laboratory for field detection. So this is a simple tool. You have two suitcases, one in which you have for the DNA extraction, you have a kit where you can extract the DNA, and you also have another suitcase where you can actually do the RPA kit. The RPA assay can be done. This, of course, is under investigation, and we hope that at one point we will be able to apply this. The next aspect is that how do we see to it, how could we think about ways and means by which cases of VL will not transition to PKDL. So that could either be drugs that would prevent VL to become PKDL, or could we think of a vaccine, a prophylactic or a therapeutic vaccine that can curb transmission. So there are a number of vaccines that are there in a research mode, but this is the only vaccine which has been applied in Sudanese PKDL. This has been done with the group of Professor Ahmed Musa and Professor Paul Kay at the University at Sudan and the York Medical School in UK, where they are at a point where they have shown that it is safe, it is immunogenic, and therefore they need to now move on to the next phase to see that really whether this would be beneficial in preventing the cases of VL transiting to PKDL or cases of PKDL being treated initially along with a combination chemotherapy. So what are the future directions that we can think of to improve PKDL case management? We can certainly, what we have shown and what has been shown in the elimination program is that active surveillance definitely has changed the scenario, and I strongly believe, and many others and all of us believe, that elimination will become a reality by 2023 or within the next few years. We should aim to improve the diagnosis, perhaps by introducing molecular tools. We can certainly improve treatment, perhaps by considering a combination therapy of liposomal amphotericin B, which is used for kala-azar, along with miltefosine for a shorter duration, and consider preventing VL to transit to PKDL, and perhaps think of a vaccine. So this is the story so far that is there with regard to PKDL, and we all need to think and be confident and know that elimination and zero transmission must become a reality. Kala-azar, of course, is akin to the rabbit, but it is not that it will lose the race, but it is just far ahead in the race, and hopefully the slow and steady we will achieve this elimination target. So thank you very much. I'm happy to take questions, and so that's what I really have to say. So shall I end the slideshow? I go for end slideshow and come back into the...
Ma'am, thank you for such a wonderful lecture. And I love the fact that you trace the entire history of leishmaniasis, and then the slide of your title talk came. And that actually was wondering, now where is the title talk? Because I was lost and most of the history of the disease. And I love the way
give a background.
Totally, ma'am, totally. And a person who's not coming from kala-azar background, this is extremely important. But everybody has a nuance of vector-borne diseases, and malaria is no different. It also has a very ancient, long-standing history, and so has lymphatic filariasis. So, ma'am, it's a beautiful lecture. I have several questions, but I think I will not take advantage of my position right now to curb other people. Maybe the house is open for questions. I'll ask my questions, ma'am, but definitely. And it was such a very over-encompassing lecture for PKDL, covering from epidemiology to future directions. Really, really enlightening for me as well, ma'am. So, because I read personally also, but for this audience and covering from end to end, very interesting lecture, ma'am. Charu, any questions on the online? Okay, Dr. Dikshit has a question, ma'am.
Good morning, madam. Thank you very much. You given information about the comparison between Asian versus African PKDL.
Yes.
So, what are the reasons behind it? Like in the years or like 0 to 1 years, I know there is 10 years. So, is it a immunogenicity or maybe feeding habits or other factors with the human population?
Right. So this is really the question. You've absolutely hit the nail right on the target. And this is a very interesting question. We still do not know. So possibly there are genetic factors which may play a role because, so I think it's important to compare the genomics of PKDL because the parasite is the same. So that's what really makes it interesting. So how does one parasite infect one individual differently and thing? So I think there are multiple factors which come into play, but most important, I think, is the immunogenomics. I think the immunogenomics, I think they are able to mount, we have a sort of a different kind of an immune response. And so we need to do a one-on-one, a head-to-head, comparison between the two. But I think the main factor possibly is genomics.
One more important point in this case we may consider, madam, because upcoming literature suggests that there's an internal factors like a feeding habit. Suppose the African population has a more like a non-vegetarian or meat and another population has a local differences. And then internal microbiome has a lot of influences. So these are the upcoming burning questions or the scientific concepts are upcoming. So we should link these biologies. Probably this will make the more
Absolutely.
clarification.
I completely agree with you because these individuals are more malnourished than the Indian counterpart. So malnourishment, immunosuppression, probably this plays a role. So the dermal macrophages where the parasite is sitting, they start multiplying much earlier than in the Indian version. So malnutrition, microbiome, these are definitely very, very important components. I completely agree with you. And we need to do a head-to-head comparison.
Because we are working on mosquito system. These are all the concepts are we are
Yeah,
building in mosquito.
yeah,
Correct.
absolutely,
That's
absolutely.
why this is the question it came in our mind. Thank you very much.
You have, okay, Dr. Prashant Malik.
It's a very nice, interesting one. It's I get whole picture. It's introductory picture of the leishmaniasis. Two questions which I don't get in the whole slide. Do we have the biomarker now or not? Means for PKDL.
We have several biomarkers, but you see what happens is that the challenge becomes is that because PKDL can occur at any time point between 1 to 10 years, so it becomes very difficult to follow up these individuals. And somehow what tends to happen, I think this is, it's a very human response, is that once you're cured of a disease, you don't want to come back, so they don't come for follow up. The cases of kala-azar, once they're cured, they don't like to come back, or be on things. So if there was a mechanism that we serially monitored all these individuals who developed weak kala-azar, and but monitoring them up to 10 years is really a challenge. So people keep asking us that, do you have the parasite which caused kala-azar and the same individual developed PKDL? Do you have the parasites? Because that would really be interesting to see that has the parasite undergone a change, that how does a viscerotropic parasite become a dermotropic parasite. Until now, I think, all researchers who are in leishmaniasis, I think we still don't have this interesting, isolate. If we could have it, I think it would add to it. So there are some immune biomarkers. It has been found that persistence of IL-10 in kala-azar cases, I think, makes them more susceptible. But this was done in the Sudanese case, where anyway 50% of them move towards it. But it hasn't been done in the Indian scenario simply because of the time factor, the logistic limitations. But it is important for us to know whether there are biomarkers that we could do, and whether there are immune, genomics, I think, would also give us answers whether there are any important differences between that small subgroup of 10% of kala-azar cases. Are these 10% different from the other 90% of kala-azar cases who don't develop PKDL? So, this would be a very good comparison, is take cases of kala-azar who have not developed PKDL for the next 5 years and compare it with those who have developed PKDL. Are there differences between the two or not?
So next question is that I didn't find that any sort of VL and PKDL in the same person at the same time.
Very rarely does it occur. Very rarely does it occur. And so this is again an important difference between the African. But there have been case reports of about 4 or 5 cases collected over maybe 2-3 years. I know that RMRI, Dr. Krishna Pandey, they have reported that there are cases of para-kala-azar. We also have found it, but it is more of a rarity than the norm. So there are individuals who have it, and we don't see any obvious differences prima facie, but what makes this individual have para-kala-azar versus others who have post-kala-azar. It has been reported. It is not that it is it is unknown.
So with the new tools for surveillance, does that figure, which is 1 to 10 years of post-cars PKDL, will reduce with
Yes,
this
yes, it has reduced. It has reduced. It has reduced. So it has reduced, and now the average gap is about 2 to 4 years. And I think it has reduced due to two things. One is because of active case detection, so people are coming forward earlier. And two is, I think, the amphotericin B, liposomal amphotericin B and miltefosine, which is being used for treating kala-azar. I think that also has helped to completely eliminate the parasite, so that there are no parasites which are remaining within dermal macrophages. Because PKDL is not unlike other cases of cutaneous leishmaniasis where it is localized. PKDL is a systemic disease. So the parasite spread through the circulation and then stays within the dermal macrophages. It is not a localized that only where the sandfly bites do you get cases. It is spread through the bloodstream. So that's why perhaps we are finding amphotericin B and miltefosine has resulted not only in a huge cell kill, the parasite load has decreased. So it is not only parasiticidal, but it is also immunomodulatory, and it has actually decreased the gap between VL and PKDL. So this is, of course, definitely another component of the elimination program and a successful component.
Thank you.
I see Dr. Rajendra's name hand up.
Hello, can you give access to Dr. Rajendra Baharia?
नहीं, आप ये ऊपर करने के बजाय उनको बोलो ना डॉक्टर बहारिया को बोलने को. क्यों टाइम वेस्ट कर? हाँ? अच्छा मैम, by the time he comes, any other person has a question?
Yeah, hello, madam. I think my voice is audible. Right? Yeah, hello. Yeah, such a nice.
Yes, I can hear you.
मिताली को लो स्क्रीन पे.
We talk about the strip test. So I think that strip test based on some kind of antigen or it's like some.
Yes, it's based on a kinensin antigen.
Okay.
So it detects antibodies. So what we require really is antigen-based tests. So there is a urine-based antigen which is available. I think it is only about 50% is the sensitivity of that. So there is a need. So this is one of the tools that we require is antigen-based tests or nucleic acid-based tests, because that would tell you that there are viable parasites that are present. So the RK39 is an antibody-based test. It's a very good test. It's an excellent test, but it can give you false results in that it could be due to a past history of kala-azar, but in the absence of any other tests available, it is used as a preliminary screening test.
Dr. Baharia, you are the co-host. You can speak your question.
Yeah, good morning, ma'am. My question is regarding diagnosis, that molecular diagnosis is the best method to diagnose the patient. But in the field condition, it is not possible to diagnose each and every person in Indian setting by molecular testing. What is the best method to diagnose the patient in the rural settings or field conditions?
Okay, so I have a different take on this, and my take is that in the COVID-19 epidemic, we were able to do RT-PCR for diagnosis, right? India did it. We did it. Real-time thermocyclers were available. We developed our own diagnostic kits. We were able to use the real-time thermocycler. So it's a question of where there's a will, there's a way. So I think that now that we have thermocyclers, I think we should now think about doing, molecular diagnostics. We should probably not think of, maybe we can, maybe a thermocycler would be a difficult option, but think of field-based diagnostic tests like we have the LAMP assay, like we have the RPA assay. So we can think of these where we can go to the primary health center and have a medical camp, because we are looking at very small numbers. So if we could have things like medical camps, we have a mobile ambulance where people, where they go around, collect all the individuals, bring them to a medical camp, they get examined, the LAMP assay is used, you diagnose it, the clinician also examines, patient treatment can be started, the individual can then be asked to come back every 4 weeks for receiving their miltefosine. So I think we can do it. It's a mindset. I think the COVID-19 showed us that India can actually use molecular diagnostics because there's really no difference, and we have that expertise. We developed that expertise also. We have we have technicians who could isolate RNA, who could do the RT-PCR. So why can't we do it also for PKDL? But maybe we should look for field-based diagnostics. This is my opinion, and I think we can do it. We should think of it in that way.
Ma'am, after COVID, there was a lot of enthusiasm about use of molecular tools in the field settings as well, and to be for wider availability. Ma'am, but somehow is it getting translated into reality? I mean, after COVID was a different scenario. It was international priority as well, and so much was at stake. So does that also go into other diseases where they're actually not that priority? Of course, elimination and political will is there, but does it really translate into that kind of enthusiastic usage?
So what can be thought of actually, because see, when you collect a skin biopsy from a PKDL patient, you don't have to test it immediately. You can just collect it in normal saline in any buffer, and the closest medical college where there is a viral research diagnostic lab, or there is a MRU, or there is a microbiology department which has a thermocycler. So we are trying to do this, and this is something that the National Vector-Borne Disease Control Program has also recommended, that medical colleges actually should be encouraged. They should be taught, because it is not something very difficult. The primer is the kinetoplast DNA. Training can be given. They can start doing this RT-PCR, and just and they need to isolate. They need to isolate DNA. They don't even. It's not even that you need to isolate RNA. So I think this momentum that we got with the COVID-19, we should continue with this momentum, so that we look at diseases which are already present, and we are also being prepared for any future disease outbreaks. So we should not abandon this expertise that we collected during COVID-19. It is something that we should actually take forward, and it's not something that we can't do. So I feel that medical colleges should be brought into the fold, especially the ones in endemic areas, and they can be taught how to do this. So this has actually been a suggestion which is there, and I think we should also have, because what I realized is that we don't actually have a PCR based. We tried a commercial test and it didn't fare as well, because that ICMR is actually funding a multicentric project for establishing a test of cure. And we actually found that the tests that we have developed in all the 4 centers is actually better than what is commercially available. So we need to do a hand holding, and we need to bring in the industry to take up this neglected tropical disease as a maybe as a corporate social responsibility, or whatever way that it can be done.
Sure, ma'am. As you said, this is already a recommendation by the for the national program, and they should actively take up mapping of the availability of these resources at medical colleges or other research institutes. At least at district level, they can establish this and cover at least the endemic states, the 4 states. That's true, ma'am. Any other question from the online participants?
Yes, there is a question here. If Madam allows.
Yeah, sure.
Yeah. So there is a question: can we give a combination of meltefosine with domperidone to prevent the side effects?
So that can certainly be done, because what tends to happen is that the nausea can become very severe. There is no drug interaction, and it can actually be given. It can be given, if the individual has severe nausea and vomiting, which is actually making the treatment adherence poor. It can be considered. It can certainly be considered.
Ma'am, I have 2 questions for you.
Yes,
And
please.
from the different angle, you showed that very beautiful epidemiological curve that there is expected resurgence after 10-15 years. When with all the efforts we bring the disease down, then there is a build-up of reservoir, and again we can see a resurgence. So maybe again this is feared by epidemiologists, that we are entering a lull phase, but we should not be too happy that we can experience a resurgence after a few years, and maybe PKDL will be the reservoir of infection. And elimination doesn't mean eradication of the disease. Elimination is less than 1 case per 10,000 at the block level. That's a technical definition of elimination. So sustenance will require constant efforts from everybody and constant pressure on the disease to be at that low a level. So I think it makes all the more sense that PKDL should be a priority for the country's program, and it has to be holistically curbed. Ma'am, you talked about in one slide, you showed that again should be thought about as a DOTS as a option for management of PKDL, directly observed treatment, because 12 weeks of miltefosine is a real long time. People can lose steam. They will not take the drug for that long. So healthcare workers should directly observe the person to take the drug. So that will be advantages for adherence. And now with miltefosine, these adverse effect of blindness, which also occurred in India, more than 12 cases have been reported. So that is actually a setback to the program to control PKDL. And PKDL, where in India, the person is not, as you rightly mentioned, there is no need for the patient to go and get treated except for cosmetic reason and aesthetic reason. But he is taking the drug from a public health viewpoint that this will curb the transmission. They don't feel the need to take the drug. You are convincing the patient to take the drug for public health good. But then he loses his sight. So he's being punished for doing a public health good. This is interpreted that way.
Yes.
So again, ma'am, it will require intense efforts on the part of the national program to engage with the people in a productive, constructive way to continue with the drug. And of course, a strong pharmacovigilance program is needed to monitor the adverse effect. But ma'am, how this will be actually translated and prevention of transmission of PKDL, a strong vector control component also has to be there, which in the national program is there via IRS, but that may not be working very well. Ma'am, how do you see PKDL control in this light? Where miltefosine has suffered a setback and there are so many things pitching on the elimination program. And ma'am, mind you, elimination program is only for visceral leishmaniasis. It is not for PKDL. So again, that takes a backseat.
So you very rightly pointed out. So PKDL always got a backseat. That's why I say a neglected component of a neglected tropical disease. So, but it should not remain neglected. So that's the way we look at it. And I think it is important that, when we look at the last mile challenges, it is not only, good methods to diagnose, good methods to treat, but also keeping in mind the vector component. So this is something that goes hand in hand. The vector component is very, very important. And, also awareness. And you very rightly said that PKDL, the person is taking this treatment. For society. So, and you very correctly said, you take it for society and you end up becoming blind. There will be no compensation. Your livelihood will be lost. So we definitely need to integrate. The vector control measures that we have. We need to look at whether there is a component, actually, like we are looking at drug resistance. We are worried about miltefosine developing drug resistance. We should also think about whether the residual spraying that we are doing, whether that also has a component, of whether there is a component of resistance or not. So these go hand in hand, and I think it's very important to train, like we trained people for COVID, we trained, technicians to do things. We also need to train this body of entomologists who need to work hand in hand, and it's important in these areas. So I know that in West Bengal, we have a very strong, there were a lot of entomologists who were employed. There are labs which are being set up. And for them also, we need to have molecular tests coming in by which they can, easily detect whether there are, molecular markers of drug resistance. So these things have to be taken up, and it has to be taken up at a national level. Once it gets taken up at a national level, there is a trickle down effect which will be seen for sure.
Ma'am, last question from my side. You spoke about the vaccine which is being tried in Sudan and it's in phase 2. How relevant that could be for India, where there is a lot of difference epidemiologically between Sudan PKDL and Indian PKDL, where the time gap is too huge in India. So how many doses will that be effective? When to take that dose, and the duration and longevity of the efficacy of the vaccine? Or for Indians, it may not be helpful?
That is that is absolutely correct. That we probably, it's a really big question. And even to undertake this study, where will you, who are going to be the individuals who will benefit? Will you give it as a prophylactic vaccine, that you give it to an individual who has kala-azar and you say, okay, let us try to prevent transiting to PKDL? If we are to think of a vaccine, we should think of it at that particular point that we don't allow a case of kala-azar if we identify markers that these are the individuals who are likely to develop PKDL. Possibly we don't look at a therapeutic vaccine, because in Sudan, probably a therapeutic vaccine would be useful. But for us, we need to think of a prophylactic vaccine. And for that, we need to know what would be the requirements. Some sort of an immunomodulatory effect We could think of drugs also in combination chemotherapy, which would be able to prevent not only the parasite kill, which would not only have parasite kill, but also have immune modulation so that, we are able to do away with those few parasites that have escaped. I call it escaped into the skin. How do we do it? These are some of the challenges, which I'm sure, researchers are thinking about. But I agree with you that a vaccine like what is being used in Sudan may not be beneficial, but I think what we need to look at is a prophylactic vaccine, not allow VL to transit to PKDL. Because even with drugs, once antimony got removed, there are much fewer cases. And we have seen, when we take a past history of what is the drug they used for kala-azar, these cases of PKDL, we still find about 75 to 80% of them are individuals who received antimony during their treatment for kala-azar, and not that many of cases of ampho-B or miltefosine develop PKDL. So again, I think immunomodulatory drugs do have a role, and this is where, research into PKDL and kala-azar this is the future that we need to think about. We shouldn't be, think that, okay, 2023, we've removed all cases of kala-azar. We should think about the fact that this reservoir needs to be, suppressed as much as possible, because we need to get them. And also, individuals, and here again, the vector can play a big role, because if you can suppress the vector, here again, you can actually delay transmission. You can block transmission. So two aspects. One is the disease reservoir, PKDL, and the other is vector control measures. So these are the two things that the future of Leishmania research should be in that direction.
Totally agree, ma'am.
I have one suggestion. Madam,
Yes.
I have one small suggestion regarding this complexity. When this parasite switch from blood to skin, so
Yes.
naturally there might be a lot of changes because it need to adapt to different environment, that blood environment and skin environment. So there are a lot of changes might be occurring. So that maybe the genetic changes is the first for this adaptation. So we need to crack this biology first. How
Yes.
parasite switch and adapt to. Because in mosquito, what we have defined, when mosquito plasmodium switch from one tissue to another tissue, there are a lot of genetic changes occur at the RNA level. So I don't know whether such studies have been done in Leishmania or not. I mean, like if we collect the sample from this skin, PKDL and blood, and we compare, so we could have a different biology, lots of the markers we can generate and can develop like immunomodulatory targets, we can do it. So because it's a biology is not known, so how it adapts to a different environment.
Absolutely.
So, and if you agree, because we are doing such a type of research, if you agree or if you want to do, we can contribute for such a part of.
We have the biological material, and I think it is very, very important. As I said, we compare the genomics, skin versus blood, and also the genomics of those who don't develop PKDL. Those kala-azar cases that don't develop, they are 80% of the individuals, and those that develop PKDL. What are the differences between the two? From there, we can actually get markers. And from there, we would be able to tell, what. So then the drugs would accordingly be designed, keeping that in mind. You could think of things. So yes, definitely, I'll be in touch with you.
So for that purpose, we will require the live material actually, so that we can extract RNA and do an.
Dr. Dixit, you communicate with her one-to-one, huh?
Yeah. Thank you, madam.
Yeah, thank
Sure.
you.
Thank you.
Charu, any other question? Or it's already 12:15. We have consumed her time of more than 1 hour.
It's been
And we
fun.
will get back to you on emails. I'm sure there must be more questions. I myself have 3 more questions, but I'm just keeping quiet at the moment. And we will reach back to you, ma'am, on emails. And we will meet shortly for that particular study's progress update.
Okay.
So
Okay.
I heartily thank you for consenting to give this lecture. And it was really very interesting for all of us and enlightening as well.
Thank you. Thank you very much. Thank you for the opportunity to speak to a wider audience.
Yeah. Thank you, ma'am.
Thanks a lot. Thanks a lot.